So vulnerable pregnant women fall into generally two groups. They can either be vulnerable because they have significant medical conditions that may result in them having poorer pregnancy outcomes for themselves and their babies, or they might be women, and they're a growing group of women who have socially complex pregnancies, and that might range from housing issues to issues around being refugees or seeking refugee status. That's obviously dependent on being in an urban area, as we are, where our local population are very transient.
I think people generally have got much more complex problems in their lives. There's a lot of unemployment, there's a lot of people who are new migrants into the country and settling in, finding out how to sort their lives out can be quite problematic to them.
The demographics of this group of women have changed. They tend to be older, they tend to be bigger, so more obesity that we see. Because they are older, they also tend to have more medical conditions which make the pregnancies more complex. And we know now, because we collect the data and we're aware that women with social complications, and again one of the bigger groups of social complexity surround women who suffer from domestic violence, for example. Those are growing groups, partially because we are identifying these women better, partially because we now have services that are fit for purpose to try and meet their needs in order to achieve the best possible pregnancy outcomes for themselves and their babies. So the impact of vulnerability is really very complex. However, just in terms of accessing care, it can be a real problem because they may not be able to get transport to come in for their appointments. They may be worried about accessing care in something as formal as a hospital setting, for example.
Making sure the mothers come for their appointments and that they understand about coming for their appointments. Because some women, if they've come from another country, they won't have as sophisticated care as we do, and they can't really quite understand why they do.
They may need to build up trust with their healthcare professionals, and that's why one-to-one midwifery care, if at all possible, is really important in the antenatal period for these women, and during labour and after delivery as well.
I try to meet all the vulnerable women we have going through. There is quite a lot of them. I see about 20% of the women going through the service. It's just making sure they realise you care. And then we will go and visit them on the postnatal ward to reassess and see if there's anything else they need, and make a discharge package for them so that they've got somewhere safe, food to eat, and they're happy going home with their babies.
In a lot of social complexity, we know from very good evidence that it tends to impact on the medical aspect of their pregnancies as well. So if they have medical complications, which we could otherwise treat well, the relative difficulty of accessing services might provide a significant challenge to us ensuring that they and their babies are kept as safe as possible. There is obviously then the issue after the baby is born. Pregnancy is a continuum, and the initial postnatal period is a period of change for most women and their families, and this can provide even more challenges for this particular group of women.
It could be making sure that if they've got a social worker, that they have a discharge meeting, that they've got somewhere safe to go and live, and making sure they've got enough food to eat. So it's referring to all the people who can help with that. And we're very lucky here that our catering department produce discharge food packages which will last women for 4 days. So we can give those to vulnerable women to take home. So it's got tins of beans, milk, things like that for them to take home if they're not going to be able to get out to the shops very quickly, or if they're waiting to get their benefits sorted out.
I think accessing care is the main thing, for them to know that the process of healthcare in this country within the National Health Service is not a punitive one, that they can access care, that our primary purpose is really to ensure that they are kept in the best possible health and that their babies are given the best possible start in life. But that's a joint venture really with these women, and these concepts sometimes can be very alien to a group of women who have trusted few other adults probably throughout their lives. And so providing continuity of care is really, really important. Having someone look after you who understands the potential complexities of what you might be going through and the stresses is equally important. I think being aware that this group of women exist is important. I think being aware of the growing numbers is important. I think sharing best practice is key and critical. As a unit, the unit that I work within has always catered for these women. We are evolving the way in which we provide pathways for them, but the care that we need to provide for them needs more resources. It needs more resources in terms of healthcare professionals who are available. It needs resources, for example, in terms of translators, and it also needs resources in terms of time and space. And those are things at the moment that are not quite reflected in the way that we are provided for financially to provide these services. I recently heard someone say that the National Health Service, in terms of human evolution, was the epitome of humanity if we get things right. And I think that if we get things right for this group of vulnerable women with social complexity, we will only improve the care that we provide to all our women across the country.